Welcome, everyone. I'm so happy to see everyone. I'm glad that we made it to the second session in October. It's been a long year, but we are very excited to have everyone. For today's session, I'm very excited to announce, to let everyone know that Amelia and Samantha are joining us today. They'll introduce themselves, but Amelia will be moderating and Samantha, both are subject matter experts, and all participants will be placed on mute, but we want this to be a Project Echo-like session. We want folks to interact with us during the discussion. Pop in your questions, introduce yourselves. We have been very intentional in carving out time and saving time for the end of the session. So the first half, we'll hear from Amelia and Samantha, and then we will have a discussion with the audience. And other than that, I think we should be, yeah, I see people jumping in, but oh, we have quorum. We should be good to go. So I am going to turn it over to Amelia.
Hey, sorry, it took me a second to unmute. What is this screen that's showing that says find? Okay, perfect. Thank you. Hi, everybody. I think many of you know me, but for those that don't, my name is Amelia Salmanson. I work at the Utah Department of Health in our viral hepatitis program. So I'm going to be doing a brief background of what a DIS is, and then provide some high-level information on how we're utilizing DIS in Utah, as well as a link to some resources and trainings, and then I'll pass it over to Samantha. Let's see. Sorry, I'm trying to move the slide forward, and now I can't. Oh, there we go. Okay. So what is a DIS and how can they benefit viral hepatitis? For those that don't know the acronym DIS, it is a disease intervention specialist. But I find this is one of the many terms that fits this person's role. It's often the definition that we use specific to a CDC DIS that's often used in SCDs. But I find that other terms for this person could be a patient navigator, a support specialist, that could also be a peer support specialist, and could also be a case manager. So in 2017, when I first started working in hepatitis, the use of a DIS was definitely a newer concept in terms of being used under the hepatitis role and specific to Hep C. Historically, as I mentioned, it's most often used with STI interventions and prevention work, but it's definitely become more common in recent years within viral hepatitis. The DIS typically have an expertise in communication, interviewing, counseling, case analysis, provider and community engagement, as well as network building. As I mentioned, they may act as a patient navigator and support specialist and often have a focus on harm reduction and linkage to care. And as we begin, working towards elimination, not only in Utah, but as you and many of your other states and jurisdictions this as well, a DIS is critical to helping link HCV positive persons to treatment and harm reduction services. The DIS, they may work for the local or state health department, but it's also something to consider in community-based organizations, syringe exchange programs, or other settings in which people with hepatitis might be interacting. And particularly for big picture elimination, DIS in all these areas is extremely helpful in linking patients to treatment and services and really meeting people where they're at. For the 2103 grant purposes, for us, we found having a DIS to conduct hepatitis C case investigations has been extremely beneficial, and that the patient may have a positive experience with the health department and utilize the health department for other purposes, for example, vaccination, STD testing, if that's available at the health department. With that being said, the work can't happen in silo at the health departments. That boots on the ground, wraparound services are really critical in supporting patients on individual basic levels, but also towards reaching our elimination goals. Okay. Sorry, I'm like technically challenged here trying to advance this slide. Okay. All right, so how did we being Utah, get here? I wanted to share a brief overview of what we're doing. So in 2017, we implemented DIS as a way to support and conduct acute Hep C case investigations, which was consistent with our 1703 grant objectives. And at the time, few syringe service providers and community-based organizations were doing rapid Hep C testing. And even more few were doing linkage to care services due to lack of resources and funding. So we were really trying to enhance this and get the ball rolling at the state department level. This did provide a centralized DIS Hep C subject matter expert. I should note prior to 17, we did not have any funding for hepatitis C. And so really we were doing very passive surveillance prior to that year. And we're not doing case investigations or linkage to care services. And I will note that having the DIS at the state health department has been particularly beneficial since the start of the pandemic, as most of our local health departments have really been focused on COVID and have not been able to work on hepatitis C case investigations. So we have actually taken that on for them over the last few years. And while linkage to care is still a challenge, we do have a lot more boots on the ground testing since this initially started in 2017, and are definitely seeing more linkage to care from our community-based organizations. Partially thanks to the 2103 funding, we recently funded 7 organizations that consists of 4 syringe exchange providers, 1 community-based clinic, and 2 community-based organizations that are expanding their services and maintaining their Hep C services due to this funding. And it's really great to see these groups collaborating and leveraging their resources. And in addition, our state DIS does support them with any training or resources that they need, and services for Hep C testing and linkage to care. Our DIS also works with these organizations to help collect that acute case investigation data that were funded for under 2103. So for example, if they're not able to contact that acute case to get the criteria and the data that we need in that case investigation form, they may work with the partner that may already have that information, or even try to connect them directly, and as basically saying this person is safe, you can talk to this person. And one other thing I do want to note is, having our state DIS and having our community-based partners, there is a really unique balance between meeting our grant initiatives and then stepping back and allowing our partners and the clinics and community based organizations to do their work. So while our DIS does and can connect patients and work with them on linkage to care, we're just one piece to that puzzle. And it's really important to see these efforts happening at all levels to try to reach the most people possible. And that's why, particularly when, I just initially said, a DIS could also be a peer support specialist or a case manager or patient navigator. It really is almost an umbrella term for people basically working with people who have been diagnosed with hepatitis C to try to meet their needs and get them to the care that they need at the time, pending obviously what their needs are. And additionally, having a hepatitis C DIS at the state level has allowed us to set a standard for working with people living with hepatitis C. Our DIS has been able to develop trainings and educational materials to improve care for this often stigmatized population. Okay, here we go with my slide change challenge. Okay, And the last thing I wanted to share were some recommended trainings and skill sets that we have found beneficial for our DIS. This is definitely not an exhaustive list, but I did want to mention the harm reduction navigator training through the National Harm Reduction Coalition. There's a lot of trainings on their website for harm reduction, overdose prevention and response, and engaging with people who use drugs. I also encourage you to check your state's resources, as many states are coming out with state-specific harm reduction trainings, and they can definitely include more state-specific rules and regulations. I know Utah has one. If your state doesn't have one, it's definitely something to consider working towards. And that's what we use to work with our partners and others that are looking to have harm reduction trainings. Additionally, I'd mentioned the CDC, DIS, and partner services. It looks like they've changed it a bit. It used to be the passport to partner services, and it still is, but anyway, they've revamped it a bit. I briefly mentioned this. It's really targeted towards STIs, and there's a very small component for hepatitis, but I did take that training at the time it was in person, and it was very beneficial, even though it was very like STI focused. I will say the online version is very dry and long, but it is a great resource. So I definitely encourage people to check out that page. And the link that I have in the presentation does have other resources for DIS as well. Another thing that I found, and I swear I'm not plugging NASDAQ just because this is their platform, but I recently discovered their Hep C Community Navigation Toolkit. And in looking through it, it really lays the framework for patient navigation and is such a great resource for Hep C case management. I probably should have just taken that and plugged it into this presentation. It would have been perfect. But I definitely encourage you to review that document. And finally, something that we've done for our DIS and we really encourage for our community-based organizations and syringe service providers that we're working with that are working towards enhancing their Hep C testing and linkage to care is having at least one staff being able to be trained on the rapid Hep C testing and counseling. And that's definitely an easier, I think, certification, but additionally being able to collect a blood draw for confirmation testing. So what we do is we provide them with supplies as much as we can and as much as our funding allows for phlebotomy, but we've also partnered with our public health lab. So if our partners do collect a blood sample, and same with our local health departments to get a confirmation test, we pay for it through the public health lab. And that's, I wouldn't say it's the most well-used resource, but it is a nice resource to have. And certainly I think I'm probably preaching to the choir here, but having as many things basically on site when you're with that person as possible is so critical to ensuring that they, being the patient, gets as much as they need in the event that that's your one interaction with them. So I'm going to stop there and I'm going to pass it over to Samantha. And I will read, while she speaks, I'll read through the chat and address any questions.
Great. Thank you, Amelia. And I can also answer some of those questions, I think, afterwards that I'm seeing in the chat. But yeah, do I have control now?
I think you're muted, Samantha.
No, I can hear her.
Oh, can everyone hear me?
Yeah.
Oh, okay. Is it broken up or? Oh, there you go. I'm getting some, I can hear you in the chat. So thanks for that, y'all. Okay, great. So I'm Samantha Euraque, and I work with the Louisiana Office of Public Health, the SCD HIV program. So I'm going to talk a little bit about that. And we actually are not using 2103 money for this program, but we know that people are still exploring the use of 2103 monies for other DIS. So in Louisiana, the hepatitis C elimination plan is obviously a multi-pronged approach. We were fortunate that we did have a big champion, which is really important, I think, when it comes to hepatitis C especially. Our Secretary of Health at the time really worked on the subscription model in our state, which happened in July of 2019. She is no longer with the state, but I think she really developed a lot of the partnerships that we're still using now. So having that champion, I would say, is really important. And also when Isabel said, we're experts, certainly people who are on this call right now were super helpful to me in the beginning when we were setting up this program. Lindsey, I'm looking at you. So part of that was a subscription model. I would say that was really the first step in making sure that the treatment was actually affordable. And so anyone who is on Medicaid would get Epclusa for free. That was the big shift. So once we had that, it really was about looking to how can we expand the number of providers that are offering treatment. So for example, we wanted to make sure that we were connecting with Medicaid and that Medicaid was working with their managed care organizations, those insurance companies, to make sure that they are providing, to their members, to ensure that they're letting them know about the treatment that is available to them. And then also making sure that they're doing the work with the medical providers and teaching the medical providers and letting them know that Epclusa is available. And that's sort of the larger work. You're gonna have to excuse me, y'all. This is the problem about doing this at home. My daughter was asking me something and being very distracting, and she knows she has to leave now. Thank you, and I really apologize for that. And so the Medicare managed care plans, especially, I think, are a huge, important part of ensuring that we have an elimination plan that really is going to reach everyone, right? And so that education really expanded, not just to them, but then our office ensured that we had provider detailers working with Champion, who is a wonderful hepatologist that is in the state of Louisiana, who is providing a lot of the education through Project ECHO. Has been huge in our state with helping to get other providers on board. Because again, when we're talking about eliminating hepatitis C, it really has to be expanded to not just have specialists providing that hepatitis C treatment. It really needs to expand to primary care providers, ID specialists, and more people feeling comfortable providing that kind of treatment. Marketing was another big part of it, not just to medical providers, sort of through the MCOs, but also directly to people. I think in the same way that we think the prescription companies like Gilead will go directly to the consumer. I think we want to make sure that our community is able to really advocate for themselves and ensure that they get treatment when they need it. So I say that to say that our program is really a small part of this much larger elimination plan. And also it's been important to have that distinction because I think often what'll happen is we say we're linkage to treatment, and then organizations will think that means that what their responsibility is to find the person and once they have a diagnosis and then just send them along to us. But our program is not that large. Unfortunately, we can't do that for the thousands of people who have hepatitis C. Another, I think, really important aspect was changing that sanitary code to make sure that we had the best data possible, which is really what helped with the collaboration that I'm going to really be talking about, which is what ensured that the Linkage to Treatment Coordinator program could exist. So the Office of Public Health, which is what the STD HIV hepatitis program is under, the Office of Public Health collaborated with the Office of Behavioral Health, who was receiving the CDC Overdose Stated Action funding. And that was a huge benefit to us, and also because we really can't eliminate hepatitis C if we're not reaching those people who are most vulnerable. And so what it allowed us to do was to really focus too on the people who might be struggling the hardest or who would also encounter the most amount of stigma when they're going to receive treatment. So in particular, our program goal, and a lot of this has been driven by the funding that we are receiving, but also because we do think it's really important to reach out to those people who we know are not receiving treatment. So it's really to link confirmed people with, to link people confirmed to have hepatitis C to medical treatment. And so again, that doesn't include those people who've received antibody testing, right? Because that could be positive, but the person doesn't actually have hepatitis C. So we're really looking at those with a confirmed diagnosis. And our surveillance team really has been pivotal and instrumental in making sure that we get good information, and that sanitary code, again, has been really, really important for that. So they look at that. The data to care model was not a huge stretch for us because we have been doing the other program that is under me is the Linkage to Care program, which is a data to care model for people living with HIV who we believe are out of care. And so we already sort of had a system set up that way. And so this wasn't a big stretch to say, how do we do this for hepatitis C? And again, it allowed us to leverage that, that funding that's specific to data to care for overdose prevention. So the linkage to treatment coordinators receive a list, and that list includes the following: Medicaid recipients, people with confirmed hepatitis C diagnoses with no record of treatment. And so they look at, you know, the prescription, if that has been written, we can get record of that. And so again, this takes collaboration among multiple entities to determine all of this. And then also we look at, do they have an SVR after they likely had received treatment, and do they have an undetectable viral load? We look at under the age of 39, and this is our proxy to find people who might be using substances, because again, we really do believe that those are the people who either, one, require more assistance and more supportive services, or who are really going to see the most stigma when they go and encounter the health system. One of the expansions that I'll talk about a little bit at the end is that we really, as a result, have started to collaborate more and more with clinics, not just our partnering agencies, but others, to get referrals, which has been helpful for them. So we're sort of finding people sooner rather than later, but we still aren't that immediate linkage. And we do have one person who does acute hepatitis B and hepatitis C, who serves as a DIS, but in our department is called a field epi. And I don't know the number of cases, of acute cases. So I apologize for that. So the program structure is we have 7 linkage to treatment coordinators, although 2 of those positions have been incredibly difficult for me to fill. And I really hope that in the next 2 weeks, I'll be able to fill those positions because we've done the interviews and we're very close. I am missing 1 lead and 1 person to cover the Southwest region of Louisiana. We decided on 7 linkage to treatment coordinators, and that was largely based on disease burden. So again, that can be problematic. You know, our data is still relatively new. That sanitary code has not been around for a very long time. So we've certainly seen hiccups there. But, you know, we really wanted to make sure we were looking at where the disease burden was and putting, you know, a dedicated person in that area to reach out to those people. So we do have, say, a coordinator who will cover 2 different regions just because we didn't see the kind of disease burden. But, you know, testing really comes into play there. If they're not doing enough testing, you know, that can be problematic. And that's certainly something that we keep discussing. We do monthly case conferences so that we can ensure that there's quite a bit of caseload management. So the staff keeps about 100 people on their caseload at a time. About 70%, 70 to 80% of those are people who they are attempting to contact. And then 20 to 30% of those are people that they're actively working with, and it's usually pretty intensive. So that ends up being, you know, somewhere around 20 or 30 people that they're really working with actively, that they're attending appointments with, things like that. And then the others are people that we're trying to make contact with. And they keep them open for 90 days. And we try to make a contact a month, and we try to make sure that we do a LexisNexis search. So making sure we're looking for other addresses that especially some of those, the clinics that might be reaching out to people don't have access to. So they do that, and then we try to roll them off and then start to contact new people. So we want to make sure we give them a concerted effort. Data recording is really, really important to the program. We use a binder. We use a binder system. So I have found that having all electronic and a completely electronic system for staff that is very mobile, for navigators, for coordinators that are out and about, can be very difficult. Whether or not the technology works where they are, all of those things come into play. Also, if they're busy with a client all day, they're not coming back to the office immediately to document that. And so what we do is we have a sheet of paper per person, and they document those things on there as they're moving around, and then ensure that they enter the data. We try weekly, but we ensure that all that data is entered by the end of that month. That is all inputted into an Access database, which is really, really struggling right now. It has become very unstable. And so we're looking at, Florida has a linkage system that I think we're gonna try to use for our staff soon. And then we have a short assessment that they do. And that assessment is really to ensure that we want the interactions to be client-led. And so if the client is most focused on food, the assessment really is to make sure that, okay, we mainly talk about food, but then later on, I make sure that I ask these questions so that if there are other services that I can connect them to, I have that reminder to do that. And this is what our event log looks like. So the staff would get into the database and then they would see this. We document the date, whether contact is made with the person, the time units, and the type of encounter. So, mail or in-person encounter service, what they did with that person, and then any referrals that were made. And this, again, is so that they can document that, and the paper has sort of the full story on the person. But when I look at the system, I can report out the services that we've been providing. And so then I can run those reports. And we also use those reports every single month to talk with staff. So this is the data that we've been able to collect. One thing I didn't mention is that part of that assessment, we do the SBIRT, the Screening, Brief Intervention, and Referral to Treatment that CMC uses. And we, again, it is a validated tool, and they've been able to do that with 163 clients. So that's out of the people that they've been able to get in touch with, which our list sort of started at about 4,000. And we started in March of 2020 was when that list was added. They've been able to do the SBIRT with 163 clients. They've offered harm reduction services to 528 clients. They've linked people to hepatitis C care, 151 people, and that is first medical appointment with a provider. And then they've been able to connect 14 people to traditional substance use disorder treatment. And that would be detox or an inpatient. Again, the focus of our program is not that. And so that is one of the things with this collaboration and the funding that I have found in the reporting. When I'm reporting back to CDC, I really have to connect those dots for them, that it isn't always going to end in a referral to a substance use disorder treatment center, but that it could be possible that, say, a person is now connected to their primary care despite the fact that they're using substances, and the substances don't create a problem for them, and now they're cured of hepatitis C. That is that harm reduction continuum that we really try to keep at the fore for our program. And they've been able to provide an array of services to 884 clients. And that could be, maybe the person is not interested in something else, but said they really had a food need, and so they connect them to that. Or maybe all they needed was appointment assistance, because not everybody is high acuity that we reach out to. Many of the barriers that we see to treatment are that people are unaware that there is treatment, although that is improving steadily. Few providers accepting Medicaid, especially in our rural areas. So really expanding those providers has been important. Identifying specialty pharmacies that will fill Epclusa, because some of them won't keep that available. And so the staff has had to do quite a bit of work with ensuring that the person sort of sticks with it and is able to get their medication. Also, the full 90 days, some providers will not do the full 90 days and want to test in between. That's been another point where we've had to do quite a bit of education, both from the provider detailers, Dr. Gia Tyson, and our linkage staff when they attend the appointments with clients. Ensuring the pharmacy receives all necessary information. I cannot tell you how difficult sometimes this can be, that they're just missing a disease code, that they're missing some other information and the pharmacy can't fill it. And that's a real big point where people will just fall off and say, this isn't worth it, especially those people who are not experiencing any issues. Behavior contracts, we have a lot of providers who will force someone to sign a behavior contract to receive hepatitis C treatment. That's been a huge barrier. And so linkage staff, again, it's important that they be there so that they can advocate for the patient and say either, look, this is a hurdle we have to jump because this is our only provider, or, you know, if we have the opportunity, talk to the provider and provide them some education around that. Misinformation about MAT, we have some providers who will say you shouldn't take hepatitis C treatment if you are on MAT, and that is incorrect. And so again, this is where the linkage staff often can be canaries in the coal mine, and they'll come back to our office and say, listen, I've got this provider who's saying this, and then sometimes we can connect them to the provider detailers and they can provide that education. Stigma, 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 I can't say it enough. The amount of internalized stigma that we see in our people saying that they do not want to go or they were embarrassed to go, and the only reason they're going is because someone called them and said, I will help you along the way. Also, the very real stigma of medical providers coming to ask linkage staff, do you know if this person is using? It seemed to me like that person was using, when it really doesn't come into play because the person hasn't missed any appointments, is attending those appointments, and is willing to take the medication. And then, of course, competing priorities. You know, lots of the people in our community are struggling with poverty, are struggling with substance use disorders, are struggling with food insecurity. And so this may not be their main priority, especially when it's not something that is affecting them. But on that note, I will say one of the big, I think, benefits to this program is that the staff, they're finding a lot of people who have chosen to be in recovery and are in recovery now. And with COVID, the fact that they're helping to connect them with a medical provider can sort of help to ensure that they're connected to services, and that hopefully they won't, because that is a very dangerous time, right? If somebody's in recovery and then they decide to use again, that's a very dangerous time where they could overdose. And so it's really important. Those are some of the dots that I've had to connect with CDC and saying, like, yes, maybe this person isn't using substances currently, but this is somebody who is in recovery, and it is a very important time for them to be connected to services. And that's really what the linkage staff does. And so in moving forward, accepting referrals has been really important from FQHCs and also treatment facilities. So when someone is coming out of detox, we can be that helping hand to keep them connected to some services, to keep them sort of focused on, you know, the benefits of not using substances, or the benefits of continuing to stay connected to a provider. Adding a measure for OUD, this is again part of the collaboration and connecting the dots, is that sometimes I wonder if CDC understands how people use substances, that it's not always opioid specific, that they might be using other things too. And then working closely with SSPs. That has been, though, the benefit of working with the CDC with this funding, is that those SSPs, we can continue to be closer and closer connected to those SSPs, so that the linkage staff can really find people who need their assistance. And then y'all fill in those 2 vacant positions. Just, I have to do it. So that's it. I know we're going to have some discussion points later, and I can go back and look at some of the questions in the chat. But if anyone wanted to go ahead and say theirs out loud, I'm looking at them now.
Yeah, and I had a bunch too that I was like thinking
Right,
I would
we have
just
that fun.
wait.
Yeah, so Isabel, yeah, do we want to just wait until then, and you can say them out loud maybe, and then we can?
However y'all prefer. What do you want to do?
Yeah. Let's
Yeah.
go back to the questions. And,
Okay, let's go back from the beginning to the beginning.
Yeah. You okay with me diving in?
Yeah, go for it.
Okay. So Rachel asked about our role of DIS in case investigations and patient navigated as opposed to classic partner services. And if anyone is doing these classic SCD services for partners and contacts. So that's a really great question, actually. And obviously, like, I will answer it, but if others have perspectives in your jurisdictions, please speak up. So we, when we initially started our project, and now I'm trying to remember if we're still doing this. We found it to not be very fruitful, but we did want to do that kind of classic partner contact tracing with Hep C, and essentially try to bring in contacts of people who are, we focus on acute cases, but contacts these acute cases, and we use oh my gosh, I'm like struggling to remember the name, and Bree, Ethan, or Allison, please jump in. But it was like a model put together with HIV, where basically, like, if the initial person comes in and brings for a confirmation test, they get, I want to say, like a $10 gift card. And then for each person that partner that they bring in for testing, they could get an additional $5 up to $35. We were doing that through our local health departments. It really, it was to try to get at that classic contact tracing, but it really was not that beneficial. I will say, though, that feedback from our syringe service providers was, if they were going, especially into, a lot of them go to people's homes and meet them, or potentially hotels, and are doing outreach there, they do try to ask about other people in the area or in the home, because likely they are using drugs together. And it was definitely better on that boots on the ground setting. So, yeah, I don't know if anyone else has any perspective on that.
I did want to say, so, we're not using DIS, but the linkage staff certainly, and this is not every time, but often the person that they're working with will bring a partner or someone that they know.
Sorry, I'm reading Rachel's response about the new CDC guidance. Okay. Sorry, I'm scrolling back up to the questions. Oh, someone asked, is anyone doing acute Hep B investigations? We don't see a lot of Hep B in Utah. We will, but we just don't see it in our state. I'm sure others do and could speak to that.
Yeah, and I think I had said, I think that that field deputy that I was talking about that looks at acute Hep C also looks at acute Hep B.
And we do, like, our project is B and C, but we just see a lot more Hep C than B. So Kelly says they do acute Hep B investigations in Philly. And I know we do perinatal as well in Utah.
Oh yeah, I'm so jealous of the perinatal because that is really not, we're not there yet.
Wait, are you talking about B or C? Sorry, I should have clarified.
Oh, I was talking about C.
Yeah, I meant B. That's a great streamlined process. I'm working on C, but it's been challenging. It is reportable, at least in our state, but yeah, we're still navigating that one a bit, and COVID kind of put me on hold for that. Okay. Okay, Kaylin, sorry, asked how many DIS does Utah have for acute Hep C? So that's also an interesting question. We just have one like state designated DIS. So it used to be me, and now it's my colleague Allison. However, we work with the local EPIs, so we're very decentralized and they all are very autonomous. Those local EPIs and nurses, we've basically provided them kind of like ad hoc DIS trainings to try to make them a little bit more sensitive, because sometimes I will say I'm pretty appalled by some of the things that come out of people's mouths that work in public health. And not like working typically with a population that uses drugs. And maybe it's also Utah, very conservative anyway. So they kind of act as that person. And then, as I mentioned, I mean, people at our partner organizations and community-based organizations are definitely playing that role, although they may call it something differently. So.
I see that. Do you have a rapid HCV testing protocol or manual? Is that the next one?
Yeah, because somebody had asked about how many acute cases we get, and I think Ethan responded. It was under my name, but about 130 to 150 per year.
And
Which,
sorry, that was the one I said I didn't have that information.
Yeah, that's fine. Yes, the next one I think we have a rapid Hep C testing protocol.
I was going to say for us, that would be a question for our, because again, in the prevention, there is, this sort of same rapid testing for HIV that's together, and they do really struggle with that linkage. I did want to talk about the difficulties that they have with that immediate linkage, because our state lab can sometimes be running quite behind. And so that has been a difficulty where our partnering agencies have had to find ways around that and ensuring that they have enough to get that confirmatory. And it's been really difficult for them to do that. So I did want to say that, and there might be a manual there. So if you want to connect with, I can ask about that and see if they have that.
Yeah, and we had put together like a toolkit for our local health departments when we first started this project, and it does. Anyway, I think we have this in like various forms, so I'm happy to follow up and make sure that something gets sent out.
Actually, wouldn't that be a good Hep TAC
request? Okay, and then I think this next one is for you.
Oh, what is it?
Or maybe both of us. I don't know. Linkage to treatment coordinators go to appointments and meet people in person, not just office and virtual based.
Yes. So, this has been, y'all, I mean, one of the things I'm probably most proud of is the fact that those are numbers. We started March 2020. We all know what happened March 2020. So the fact that they were able to connect with anyone I felt impressive. And so there was a lot of creativity that went into that. So, initially it was all done by phone. But then as things, as we felt more secure that staff could meet people and, not put anyone in any kind of danger, then they were meeting with people outside on their porches. They were meeting with people at the libraries. And then as long as the clinic allowed it and their protocol allowed it, they absolutely attend those appointments. And I will say right now, we have a travel restriction, and the people that are most upset about that are our linkage staff, because they know just how important, and for HIV certainly also, and especially for hepatitis C, because, often it's getting that foot in the door that is the most difficult. And so if they can say, look, I'm going to meet you there, it just makes all the difference. And so they've really, really been pushing back on seeing how we can, because we have a travel restriction right now, how we can, do that safely. Because of course, safety is absolutely the main priority, but we also know just how important it is for them to attend those appointments. And truthfully, that is the only way that we've been able to see that there are behavior contracts, that there are these things that no medical provider would actually say that they're doing, right? When they go to those trainings, they say, absolutely, I will provide the treatment. I want to provide the treatment. They just don't come. They don't show up. It's always the patient's issue. But if it's not for the linkage staff going to the appointments, I wouldn't be able to then say in our larger meetings, look, our providers are still stigmatizing patients.
I have a follow-up question to that, actually, because we just recently, as I mentioned, we recently started funding, one is a clinic who they're actually associated with a substance use treatment facility, and they are definitely one of the, I would say, leaders in working with people who use drugs and treating Hep C in the state. And then we have like our other partners in that we're funding, and even the ones we're not funding. And I'm curious with your kind of patient navigation or, people going to these appointments, and then do you have them sign like MOUs or anything? Because we're trying to figure out the best way to have all of our partners that may be seeing some of the same people, whether it's at syringe exchange and then at the clinic, like knowing basically, and I think this also goes to that system you mentioned that Florida is using to track. So my question, I guess I have a two-part question. Like, are there any MOUs or MOAs that you guys have in place to do this? And what is the system that Florida uses that you guys are looking at, if you know the name, and it's okay if not?
So the MOU, I have tried to do MOUs, but I feel like anytime we have done them, it doesn't end up going anywhere. Like, I feel like everybody's like, yeah, we'll sign that. It takes forever through, our bureaucracies. And then ultimately it's that, as long as the partnering agency feels comfortable sending them to us, we are very clear with them that we cannot provide them with any information that the client has not allowed us to provide them. Right. And since my program in particular, it is also particular to mine, because I will tell you, I think in the prevention with that immediate linkage, there probably is, more and I would say it's probably a CDA, like a contract that they're doing, and they have that written out there. With mine, since the people are out of care, I think agencies are much more willing to be like, look, we weren't able to do anything. So yeah, take it. And if we don't get anything back, then we don't. So hopefully that answers your question there, but I do feel like they are helpful. And I do, wish, because I always prefer to have something in writing. But as long as we're not, as long as we don't share with them, they really, haven't had much problem sharing with us.
Yeah. And I see it more even as just, even if DOH, Department of Health, is out, but like the partners themselves, like the people on the ground that are like, like, oh, I saw this client the other day. Oh, I saw them too, like kind of connecting that dot. But I think they're weary to talk to each other about it because they want to keep that trust and obviously not break any privacy.
Yeah, I think that can be hard. And then your second question, it's the Florida linkage module is what we've been calling it. And this is through funding with Georgetown. They have been, we have some funding, oh man, and I can't remember a number or name, but they're helping the surveillance unit. And so through that, that's how they were able to, Florida is also one of their funders, and they were able to connect with them. And then we're looking at your EpiTracks, of course, which we are, think is great. And I think that's what Florida calls it. But is anybody here from Florida? Anyone on the call in Florida? I can see that. And then the next question, this was Rachel. Thank you for posing this question. This is one of the questions raised in the recent article on DIS for HCV is whether it is more cost effective to just test and link in high prevalence settings versus doing data to care. We're funding both and curious about which will be more fruitful. I think I have a lot of caveats there. With us in particular, since we're trying to find a very particular population that isn't connected to care anywhere else, I think that's where, for us, I don't know how we could look at that sort of cost effectiveness because they're not in care at all, right? So if it wasn't for this, what is there? But I think that's a question we're always asking. Sorry, I don't have an answer necessarily. But if you have follow-up for that, or if you want to talk more about it, I'd be willing to. Because I think I have the same question always with HIV.
Yeah, I try to not get in the way of the health department.
And I mean, testing and linking on site. Yeah, I mean, when you say that too, we are, all of our health system is disjointed. And so I think if there was the option, we would absolutely be doing that. But for us, that's not an option here in Louisiana, unfortunately.
It sounds like what you guys are doing is awesome. I was taking some notes myself on ways we could improve.
Well, thanks. I mean, they certainly feel like they're connecting with people. Yeah, I mean, on site, y'all, it's because our health system is so disjointed. I love all the comments because, I don't know, I often say to my staff, to both HIV and hepatitis C, is that I never want them to just be Band-Aids for a broken system, but the reality is they are, right? Because if you went to one place and got tested and then they gave you treatment, we wouldn't have to have people running around like crazy, sending records here, sending records there, talking to the pharmacy out here. You know, that is the biggest issue I think people encounter, and then the stigma.
Mm-hmm. Yeah, I mean, myself, like if I were to switch doctors, I have to get, unless I'm in the same like healthcare system, fortunately, but if I switch, like I have to get everything transferred. And and I'm not like a stigmatized population that's like struggling to try to get resources. So, somebody asked, has anyone been able to utilize immunization funds for Hep B investigations? Curious if anyone has input on that.
I'm out.
Same. We use the 2103, but like I said, we just don't have a high burden of Hep B in Utah.
And I will say I'm not sure, so I wouldn't be able to answer. And then Amelia, did you see Rachel's comment? She said our state has funded Medicaid whole person care initiatives. Yeah, that's really great.
Yeah, I wrote that down. I will say that getting Medicaid to engage with us is one of the biggest hurdles we're having in Utah and have been for years. I just put feelers out to have like our first like elimination meeting in December. And I do have a connect from Medicaid and they are supposedly very excited to join the conversation. So I have hopes, but yeah, it's been a challenge. And I'm sure others experience that as well.
And I think the last one that's here is, how does your program obtain contact information to engage individuals? For us, it's data to care. And it uses information from Medicaid, from the labs, and from medical providers.
Yeah, we have a great surveillance system in Utah, EpiTrack. Samantha kind of mentioned it. And, we do typically get contact information through electronic lab reporting. If not, we can typically see the provider, or if it is in a more alternate setting, follow up with them and try to get contact information or even ask them for the information on the patient. I love that Samantha said they have LexisNexis. I know it's something that's people have gone back and forth about in Utah, because even with any infectious disease, like trying to contact people and make sure that that's right and find alternative addresses is challenging. I do know LexisNexis is fairly expensive, but I will say we don't have it right now. I use the internet a lot. Maybe I'm just a creepy stalker, but I've been known to we try to use as many alternative ways to contact people as possible, including Facebook messaging, which I think is technically not allowed, but I have done it.
It can get really iffy.
Yeah. You have to be careful, but I've also found alternative numbers for people and okay, worst case scenario, you call and it's not them, so.
Yeah, I'll actually say one of my linkage staff is an amazing sleuther and rarely will send me Lexis. So I'm the only one with the LexisNexis license in our group. And so they send it to me and I look it up and I send it back to them. And she will find a way to get in touch with at least one family member. It's amazing. Although sometimes it doesn't really lead to anywhere, but I do think there are other ways, but I do think it's helpful.
So Danica mentioned they're doing something similar to what Samantha's doing, where they find people that are out of care and use LexisNexis if they're off the grid. Yeah.
Which is why I will say, Danica, that this is why the SSP collaboration, I do think, has become more and more important. So for example, I can only think of one right now, but there's an SSP that one of the LTCs works with and there's a person who comes there who doesn't have a phone or uses someone's phone sometimes, and so uses a coordinator at the partnering agency's phone and uses that phone to contact the LTC when they need something. So, I mean, some of the ways that they can sort of get around that, and this is absolutely somebody's off the grid. If we looked on LexisNexis, we would probably see 10 different addresses in 10 different states. But, you know, I think that's why that sort of connection with the SSPs is really important.
I do also look people up in their arrest records to see if they're currently incarcerated. And
Ours
now
are not so great.
Yeah, ours are kind of random. Now I have a pretty good connection with the prison thanks to COVID. And so I sometimes will just be like, is this person incarcerated? But yeah, I also mentioned WhatsApp. Just because some people, like, they don't have a phone plan, but if they're on Wi-Fi, they can use WhatsApp. Yep. But also, I mean, like I said, I think a lot of our boots on the ground people are really critical to doing this work. And I wish we were more boots on the ground like you guys, Samantha. Like, it's awesome what you have going on.
Thank you. I appreciate that. But I will say there is still a very large distinction between what my staff are doing, and then we also have some community health workers that largely work, you know, well, with all testing, but they're the ones that are really out there in the community, you know, going to areas where they know people either live or hang out. And so, you know, there's still a big sort of difference between, you know, like the people I think we're contacting and then the people that they're able to engage with. Oh my gosh, once they leave prisons, yeah, y'all, it's so hard knowing when they're getting out, when they're in. Yeah, we really struggle with that.
We're trying to like, because like I said, we're focused on, oh, that's awesome. We're focusing on acute cases and like working with corrections to get some of the data components we need to meet our grant initiatives with the prison is like, it's been interesting. Like, and it just like to what Samantha was saying earlier, I mean, our health systems are totally broken. So like, I understand people get squirmy about having basically one giant system where you can see everything, but it would be very nice. Yes.
Because they won't take labs. We have to try to get the labs, you know, because the providers want to see a lab before they'll even, you know, look at the person, and they can't even get one appointment. I mean, it's just, it really is difficult.
Yeah. I will say we're kind of coming up on our last few minutes here. So I don't want to go over.
Yeah, and I did want to plug before we get to go, because as I said, Lindsey Sizemore was super helpful to me in the beginning. And I did want to say, I'm not going to lie, when I used the HepTech initially, I was like, why do I need a middle person? This is taking longer. But the truth is, I think it kept us accountable. And we were able to share information, and it was super helpful in just seeing if I was going in the right direction, if I wasn't, what kind of changes we could make. So, you know, I think all of that was really helpful, those conversations, and the fact that NASTAD could help facilitate those. I appreciate it. And if anybody wants to reach out. I don't want to interrupt you.
Yeah, and I'm fine to stay on. I know some people probably have to jump. So
I will say this. I need the people. I need y'all to fill out the evaluation survey. Please. Here's some data that we can show. It seems like generally, as we continue to improve our processes and et cetera, overall satisfaction is increasing and our promoter score as well. But we need more respondents. Please, 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 please. This is how it helps to inform our TA. And so we are absolutely being mindful to make sure we carve in time for presentation and participant engagement, which I believe is reflected here. I mean, could Amelia and Samantha have engaged better with the audience? No, they could not have. That was perfect. It was beautiful, organic. Thank you so much. All recordings can be found on our microsite. Email hepatitis@nasdaq.org with any questions. And I am going to stop the recording.
Did you see that question, Isabel? What is a promoter score?
Oh,
wondering
it's
that
how
too.
likely, promoter score is how likely people are, how likely they are to recommend the VLC to their colleagues.
Oh.
Yes, yes. Yes. Thank
Yeah.
you, Samantha.
And
Yeah, I love it. We're like Brangelina now.
oh my gosh, I wish. I wish I was Angelina, I should say, because Brad Pitt, whew, heartthrob. He could be my dad, but it's fine.
I wish I was Brad Pitt.
Um,
Angelina, who?